Hello. Um, it said all attendees in listen-only mode, but I hope that everyone is hearing me. This is Dana Murphy-Parker. I am currently the president of the International Nurses Society on Addictions, and so I'm very happy to be able to welcome you to our webinar this afternoon. I need to let you know that this webinar is made possible through a grant to the International Nurses Society on Addictions in collaboration with the American Academy of Addiction Psychiatry. These webinars focus on education of opioid dependency and the use of opioids. It is a 3-year grant that will be ending in February 2018, and this is the 7th webinar of the series. As we go through the webinar, we do encourage your questions. You can type in your questions at any time using the chat bar. However, they will not be addressed until the end of the webinar. I believe Dr. Cheadle will present for about 50 minutes, and we'll leave 10 or 15 minutes at the end for questions. This webinar has also been approved by the California Board of Registered Nursing for up to 1 contact hour, and each attendee will receive a certificate upon completion of the webinar survey. The survey link will be sent tomorrow by email. I have the real pleasure of introducing to you Dr. Martin Cheadle. Dr. Cheadle is an associate professor and a clinical psychologist at the Perelman School of Medicine at the University of Pennsylvania, and he is an expert in pain management. Dr. Cheadle, I had the opportunity to see talk last year at the ISAM conference, which is the International Society of Addiction Medicine, and that was in Dundee, Scotland last year. And he gave a very interesting talk, one of the most interesting talks I've heard to date on pain management and addiction. So with that, I have the pleasure of introducing to you Dr. Cheadle, and I'm just going to go ahead and turn it over. Dr. Cheadle?
Thank you, Dana. Now I owe you $10 for that nice introduction. First, I want to thank the organizers of this educational webinar for inviting me to discuss this really important issue of prescription opioid misuse and abuse in general, and more specifically the new CDC guidelines for prescribing opiates for chronic pain. Just some housekeeping. If we can get this to work. I have no conflict of interest regarding the material in this presentation. And the target audience, as displayed in this slide, is to offer evidence-based trainings on the safe and effective prescribing of opioid medications in the treatment of pain and or opioid addiction or opioid use disorders. It's a focus to reach providers and our providers in training from different healthcare professions, including physicians, nurses, dentists, physician's assistants, pharmacists, and program administrators. So the 2 educational goals for this educational webinar is to, 1, explain the differences between the CDC guidelines and the previous opioid prescribing guidelines. There's been many iterations of these guidelines, both at the state level, at the federal level, and we really want to understand how this has evolved and how these guidelines are different. And secondly is describe at least 2 challenges in applying the CDC guidelines into practice. Guidelines are one thing, but actually putting these into practice is another matter. So let's start first with looking at patients with pain. So patients who develop persistent pain often present with numerous comorbidities. This includes sleep disorders, depression, anxiety, secondary medical problems. They have weight gain, which will lead to obstructive sleep apnea, or hypertension, diabetes. Many develop functional disabilities, cognitive distortions, and a subgroup will misuse and abuse their prescription opiates. Now, it's interesting, the Institute of Medicine got a group of experts in the field together and put together a manuscript that named Relieving Pain in America, a Blueprint for Transforming Prevention, Care, Education, and Research. This was published in 2011. Some really pertinent facts came out of this manuscript, including that about 30% of 30% or 100 million adults in the U.S. Deal with chronic or recurrent pain, and it's on the rise worldwide as baby boomers get older. The annual cost of chronic pain is estimated to be between $560 to $600 billion. This includes the cost of healthcare utilization, lost productivity if there were jobs, and certain really other facts that are important is that disablement from chronic pain affects everybody. It's not just the pain sufferers, but it's their families, their workplaces, and society in the whole. You know, pain is part of the human condition, both emotionally and physical pain. It's hard to get out of this world without suffering pain. And protection from and relief of pain and suffering are a fundamental feature as well as a cardinal underpinning of the art and science of healing. 90% of the people who present to primary care physicians present with complaint of pain. So let's put this in perspective. We look at prevalence of pain versus your heart major diseases. And as you can see, the pain is significantly more prevalent than diabetes, heart, and cancer almost taken together. So this isn't an inconsequential problem. The cost, again, putting this in perspective, in billions to America, if you look at pain at being almost $700 billion as compared to heart disease. So again, this is a major problem that needs further attention. So the IOM report really challenged all of us in the healthcare community to really look at some basic guiding principles. Number one, effective pain management is a moral imperative. If you're in clinical practice or you're an administrator involved with training programs, this is not something that can be ignored. Everyone has a responsibility to take care of their share of patients who suffer from chronic pain. Secondly, pain should be considered a disease with distinct pathology. Somehow we think of pain as being a psychological or psychosocial phenomena, when there's really good evidence that when pain becomes chronic, anything over 6 months, that it actually becomes a brain disease, not dissimilar to addiction, and is real, just like diabetes. And when I talk to my patients the first day when I meet them, I say, look, having pain is like being a diabetic. It's real, it's not going to go away, and the goal is to improve your quality of life. You start setting the bar and expectations in an appropriate manner. And then we treat pain as a disease, again, rather than a psychological phenomenon. It's very important to have that therapeutic relationship with your patient. Next, there's a need for interdisciplinary treatment approaches, and we'll talk a little bit about this later in this presentation, but interdisciplinary pain care is the only model that is effective. However, there are scant number of these programs left in this country, and this needs to be addressed. And lastly, in the focus of this webinar, is there is a serious problem of diversion and abuse of prescription opioid drugs. So let's look at pain and prescription opioid abuse. How did we get here in 2016? You know, what's the history of pain and prescription opiates? Well, if we go back in the 19th century, opiates and cocaine were virtually unregulated and were prescribed for a variety of ailments. If you look at the right side of the slide, the Bayer and Company actually came out with heroin over the counter, and you could buy syringes at Sears and Roebuck and take care of whatever ails you. There was a cocaine toothache drop, so the children were always saying they had toothaches. So basically it was completely unregulated at that point. What happened was the Harrison Narcotics Act in 1914, and what they decided was to formulate to regulate the importation, exportation, manufacture, and distribution of opium and cocaine. So this was confirmed by the Supreme Court in 1919, stipulating that doctors could not prescribe maintenance supplies of opiates to addicted patients. Addiction was not considered a disease. It was more of a moral failing, and physicians who prescribe opiates to addicts were censored, lost their license, and in some cases were actually imprisoned. So at this point, addiction was criminalized, leading to the undertreatment of legitimate pain. So what happened over the years? There was a lot of advocacy for humane treatment of pain by grassroots and professional organizations, and there were several published articles in the early 1980s that basically proclaimed that opiates were safe to people with chronic non-cancer pain, and that these were, somewhat considered to be misleading, that the people who had chronic pain were actually a low liability of developing an opioid use disorder, and that the efficacy of opiates were very important and in the non-cancer patient population. And this led to the adoption of what's called the Intractable pain statutes. So at this point, pain management became opioid management. Now, this was the focus of how we treated patients with pain going into the 80s and 90s. And this was developed for a number of reasons. It was a very unidimensional and a unimodal approach to pain therapy. It was much easier, much more convenient for people to prescribe opiates. A colleague of mine said it takes 30 seconds to say yes to prescribe an opiate and 30 minutes to say no. It became the focus of the pharmaceutical industry with a lot of publications regarding the importance of treating non-cancer pain. And they used the opioid model from end-of-life and cancer population generalized to those with pain of non-cancer origin. So what this led to was excessive prescribing of opiates, and we started to look at some of the aftermath. This is looking at first-time use of specific drugs among persons greater than 12 years old, and this is a 2011. You could see that marijuana was number one on the hit parade, but right behind it was pain relievers, and you can look as it go down to tranquilizers, ecstasies, down to heroin. So we started to see this shift of first-time use. Now this slide is very telling. As you look at the rise of the sales of opiates, this was paralleled by the number of deaths from opioid-related association. And this was also paralleled by the number of people being admitted for opioid use treatment. Now, if we look at the deaths for prescription opioids, you need to be very clear, though, that 75% of those deaths were by non-medical users. These aren't representative of people who legitimately were prescribed opiates. And you need to keep that in mind when you look at any of this data, how many were non-medical users and how many were not medical users. But the point is, as the sales went up, there was more diversion of opiates into the community aquifer. Now, something that's sometimes overshadowed by our focus on opioid misuse and abuse is unintentional overdose and suicide. I was at a national meeting and we were talking about unintentional overdoses, and I meekly raised my hand and I said, well, how do we know they're all unintentional? These are very brittle people. They have significant psychiatric comorbidities. Maybe a subgroup of these people are actually committing suicide. Well, here's some data to support that thesis. So as the availability of prescription opiates increased from 99 to 2006, there was a paralleled increase in opioid-related fatal poisonings. Well, if we look at the increase in the emergency room visits for suicide attempts, all drug-related increased from 2005 to 2007 by 30%. Opioid-related went up by 55%. So when we're looking at the opioid epidemic, we also have to look at some of the other factors that might contribute to the fatal overdoses. So here's where we are. We have the pendulum of policies in opioid prescriptions. Opiates are good, opiates are bad, opiates are good, opiates are bad. So we go from one end where it's unregulated and you can buy heroin over the counter to current statuses where opiates should not be used for the variety of pain disorders. Where are we and where should we be with the use of this molecule for patients? Because we really do have a treatment dichotomy. This is a molecule who can help a subgroup of legitimate pain patients to not suffer, to be more functional, and to improve their quality of life. However, there's also a subgroup of people who, once exposed to opiates, goes to the reward system and can lead to the development of an opioid use disorder, and by the prescription of opiates regulated manner leads to an ample supply in the community for diversion by non-medical users. So where can we find this balance, which is important? First of all, what is the true incidence of prescription opioid abuse in chronic non-cancer patients? See from this slide that the data is all over the place. So anywhere from 3% to 62% of chronic pain patients receiving opioid therapy display some type of problematic opioid taking behaviors. That could be frequent visits to the ED, lost prescriptions, asking for early refills, which are not necessarily symptoms of an opioid use disorder, but of aberrant behavior. And this could be due to undertreatment of pain. It could be to use of opiates for non-pain relieving effects. Now, the reported prevalence rate of substance dependence, or what we now call substance use disorder, ranges anywhere from less than 1% to 40%. Well, why is that? Well, first of all, the definitions of misuse, abuse, and addiction are inconsistent across all studies, and behaviors evaluated vary in seriousness. There are poorly standardized methods to detect these outcomes, and data from efficacy trials tend to underestimate risk. So what is the difference between misuse, abuse, and addiction? So a lot of people have spent a great deal of scholarly activity trying to define this. And so what the consensus is by most experts is that misuse means that you are using a therapeutic agent for what it's therapeutically intended, but not as prescribed. So you're prescribed to take 2 Percocets a day and you use 3 a day. That's misuse. Abuse is for using that therapeutic agent for what it's not therapeutically intended. Now, this could include seeking some type of euphoria. It can also include using it to self-treat an anxiety disorder or a depressive disorder, because we know that opiates in some people serve as anxiolytics, anti-anxiety, and also hedonic or antidepressant effects. Many of my patients will use opiates to induce sleep at night, because anywhere between 50 and 80% of pain patients have sleep disorders. But by definition, that's abuse. Now, addiction is a different bird, and that's really that out-of-control use, that compulsive use, that negative consequences and craving, which really characterizes someone who's developing an opioid use disorder. So a lot of the data that has been published on the prevalence of opioid abuse and addiction is really tainted by not having clear definitions. And again, who's making the diagnosis? Many of the studies are data dumps of retrospective reviews based on ICD-9 or ICD-10 codes. Again, who made that diagnosis of an opioid use disorder, which is extremely complex in patients who have pain and are receiving opiates legitimately. So we really need to have some more work on standardizing these definitions when we're looking at prospective studies. So here's 2 interesting studies by Boscarino and his group. First one was in 2011, and what they did was to use the more sensitive DSM-5 criteria for diagnosing opioid use disorder, where you exclude tolerance and dependence if they're actually taking a prescription of a medicine that can lead to those states. So they looked at a large group of patients, these over 700, with chronic non-cancer pain that were receiving long-term opioid therapy. And they did this DSM-5 diagnostic interview on all these patients. And what they found was that the prevalence of lifetime opioid use disorder was 34.9%, and that 21.7% of this population met criteria for moderate opioid use disorder, and another 13% for severe opioid use disorder. In a subsequent study, they looked at another large cohort of patients with chronic non-cancer pain on opiates, and again, using the more sensitive DSM-5 criteria, they found that in this patient population, that 41.3% met criteria for a lifetime prevalence of any opioid use disorder. What this tells us is that the incidence of opioid use disorders is not inconsequential in patients with chronic pain. So what have we done to reduce the risk, maximize benefits of opioid therapy? Keep in mind that opioids can help a subgroup of patients. So we don't want to throw the baby out with the bathwater, but we need to be able to really separate who's at risk, who's not at risk, and to really minimize the risk of either developing an opioid use disorder or having some type of opioid-related fatality while protecting access to patients who benefit from this therapy. So here's a number of strategies that have been employed. So there's risk assessment and monitoring, so urine drug testing, risk assessment tools, and prescription drug monitoring programs, which exist in most of the states. Clinical education, which has not fared very well, but for example, using the REMS or the REMS program for opioid prescribing. And lastly, and the focus of this webinar is the development of practice guidelines. So let's take a minute and look at the evolution of opioid prescription guidelines. So there's a number of different guidelines out there. There's the American Pain Society and the American Academy of Pain Medicine guidelines, the Canadian guidelines for safe and effective use of opiates. The Federation of State Medical Boards has had a number of different evolutions of their guidelines. And then most states have their own guidelines, which are very similar but may vary in terms of what they consider high dosing of opiates and other subtleties. So in a systematic review in 2013, a number of these opioid guidelines were reviewed, and 13 met selection criteria. And of those, 2 were considered the highest quality. The American Pain Society and the American Academy of Pain Medicine clinical guidelines for the use of chronic opioid therapy and chronic non-cancer pain, and the Canadian guideline for safe and effective use of opiates for chronic cancer pain. The majority of the recommendations from all the guidelines were based mostly on expert consensus opinion or observational data. There's not a lot of data even to date that is really a high standard of research integrity, which we'll talk about. So of the 25 recommendations from the APS-AAPM guidelines, 21 were supported by only low quality evidence, and the remaining 4 recommendations were only supported by moderate quality of evidence. In the Canadian guidelines, there were 24 recommendations, of which only 3 were based on random controlled trials. So a preponderance of the guidelines had very similar recommendations. Number 1 is opioid dosing be no greater than 90 to 200 milligrams of morphine equivalent. Now again, that's a range, and we'll talk about how that's been altered in the CDC guideline. But in the state of Pennsylvania, where I am, our state guideline says that high dosing is 100 milligrams of morphine equivalent daily dose a day. Washington is 120. There's states that have 80. So there's a whole variation in what's considered an upper dosing of opiates for chronic non-cancer pain. Almost all guidelines are very clear in suggesting that methadone should be prescribed judiciously due to its very unique pharmacokinetics and pharmacodynamics, and only after the practitioner has acquired additional training. The risks of fentanyl patches should be acknowledged, again, for the same reasons. A lot of variability between individuals in terms of their response to these medications. The clinician should be aware of drug-drug and drug-disease interactions, and there's some utility in the use of risk assessment tools, treatment agreements, and urine drug testing. Almost all of the guidelines suggested using the standardized risk assessment tools, also suggested using a treatment agreement to establish goals with the patient, and the use of urine drug testing. And we'll talk a little more later. We will talk later about the specifics of these. So let's focus our attention on the newest guidelines, which is the Center for Disease Control and Prevention Guidelines for Prescribing Opiates for Chronic Pain, United States 2016. So let's walk through how these were developed. So they use a standardized guideline development based on the grading of recommendations, assessment, development, and evaluation methods. So this is a website if you want to understand more about how that was developed and how they assess evidence. If you really you have to look at the type of evidence that supports the recommendations of the consensus group. So there's really 4 types. Type 1 evidence is really the gold standard. Randomized controlled trials are overwhelming evidence from observational studies. We all know in research that randomized controlled trials are the gold standard, and this is what we're trying to standardize all research on, particularly when we're making meaningful recommendations that will affect millions of people. Type 2 evidence is randomized clinical trials with important limitations or exceptionally strong evidence from observational studies. The third type is observational studies or randomized clinical trials with notable limitations. And lastly is the type 4 evidence, which is clinical experience and observation. So it's sort of a consensus group's clinical background and what their sense is of what is appropriate treatment and recommendations. Observational studies with important limitations, or randomized clinical trials with several major limitations. So as we go through the recommendations, I want you to keep in mind this numeric, the 1, 2, 3, 4. So type 1 and 2 are the best level, 3 and 4s are less supportive evidence. So they also looked at recommendation categories. So the group of experts looked at Category A recommendation, which should apply to all persons. Most patients should receive the recommended course of action. Category B recommendation is individual decision-making needed, looking at individual differences. Different choices will be appropriate for different patients, and that the clinicians help patients arrive at a decision consistent with the patient's values and preferences. Again, a collaborative model of working with your patient and looking at specific clinical situations. So who were the experts that were part of the CDC? So the CDC solicited experts to review the evidence and assist in writing the guidelines from a number of organizations, leading PCP professional organizations, which is critical since the majority of pain patients are cared for by primary care physicians and clinicians. state agency officials, the policymakers, people that have been doing work in opioid prescribing, pain management specialists, and substance use disorder treatment. So they had a real nice balance of different types of folks that can contribute to this process. So let's start going through each recommendations and some qualifying remarks on each one. So recommendation 1 is determining when to initiate or continue opiates for chronic pain. So number 1 recommendation, non-pharmacologic therapy and non-opioid pharmacologic therapy are preferred for chronic pain. So this has been kind of the hallmark of the CDC guidelines, and while other guidelines have also recommended this, I think the CDC guidelines really emphasize this more. They've added that clinicians should only consider opioid therapy if the benefits for both pain and function are anticipated to outweigh risk to the patient. You know, have we tried everything we can short of opiates? What's their risk profile? If opiates are used, they should be combined with non-pharmacological therapy and non-opioid pharmacological therapy. Now that was an evidence type 3, but a strong recommendation of category A. So if you think about it, as I pointed out in my first slide, patients with pain are complex. They have multiple psychiatric and medical comorbidities. And I think it's very naive that we have a one hammer and everyone's a nail, that only opiates or some other molecule is going to be effective in treating all the different facets of chronic pain. So I think this is a very important recommendation, and it makes good sense that we should use everything at our disposal to help treat this complex case. Next point was opiates should not be considered first-line therapies for routine therapy for chronic pain and only should be considered first-line therapies for active cancer patients. Now this is pain 101 basically. You know, first you have to decide what type of pain are they having. Are they having neuropathically driven pain? Are they having visceral pain? Are they having musculoskeletal pain? Because there is overwhelming evidence that opiates are really not the first line of therapy. But this is where we're going to talk about later about some of the deficits in training, is that people are not trained in pain medicine. So, for example, fibromyalgia, if you look at all the guidelines for fibromyalgia, what is recommended? SNRI antidepressants, anti-epileptic drugs like pregabalin or gabapentin, sometimes tricyclics. If there's opiates, they're usually 10th or 12th on the list. Low back pain. You know, if you look at the consensus guidelines for low back pain, what are first-line treatments pharmacologically? Acetaminophen, non-steroidal anti-inflammatories, tricyclics. So again, opiates are not the first line. Complex regional pain syndrome. What's the number 1 drug of choice? The first-line therapy would be something like gabapentin. So again, opiates for some reason have become the first-line treatment for unclear reasons, because they really are not the drug that targets most of these pain conditions. Second recommendation, before starting opioid therapy for chronic pain, clinicians should establish treatment goals with all patients, including realistic goals for pain and function, and weigh how opioid therapy will be discontinued if benefits do not outweigh risk. They should only continue opioid therapy if there is a clinically meaningful improvement in pain and functionality, and this outweighs risk. So let's look at this from a more granular perspective. There's been a lot of debate recently about using pain intensity as our gold standard. It's being removed as sort of the 5th vital sign because it's really not a predictable type of outcome, and it's hard to measure. What is an 8 for one patient is a 3 for some other patient. If someone has a 10% decrease in their pain intensity, are we really achieving goals? There's been a lot of sense among many of my peers that we really should look at function, which is a little bit more realistic, and mood. And so when I see patients, their pain intensity is less important to me. And if they're started on an opiate and they come back and they're more functional, they're playing more with their kids, they're went back to work, they're doing volunteer work, and their mood is improved, then maybe this is a good target for the opioid therapy. But again, I think you get into a trap looking at pain intensity as a marker. Goal setting is critical. So most people in the field always recommend that you start before you start opioid therapy, you have the patient sign a treatment agreement. And that treatment agreement typically lays out what your responsibilities are as the clinician, what the patient's responsibilities are, what the potential risk of opioid therapy are. But usually many of them do not have specific goals, or if they do establish goals, they don't revisit them on a regular basis. So I think the CDC is trying to make a point here is that everything should be goal-driven. If you're treating someone for hypertension, you have a goal in your mind of what type of reduction you want in measurements, or blood work if you have the right therapy. This should be no different in pain. It's a little trickier, though, in trying to get very specific outcome measures. But again, everything should be goal-directed no matter what you're prescribing. They recommended further that starting and periodically during opioid therapy, they should discuss a patient's known risk and realistic benefits of opioid therapy, and a patient and clinician responsibilities for managing therapy. Again, type 3 evidence. The clinician should ensure that patients are aware of potential benefits of harms and alternatives to opiates before starting or continuing opioid therapy. Now, what does this mean? This means that you need to have a good discussion with the patient so that they're clearly understanding, and this is really informed consent, which is not typically part of the treatment agreements. It should be a separate discussion about here are the things that could happen with chronic opioid therapy. And an addiction may be low on the list. It may be androgen deficiency. It may be opioid-induced constipation, pruritus. I mean, I think that you have to really have a discussion with the patient so they clearly understand what they are getting into when they are starting long-term opioid therapy. And that they further went on that the clinician should emphasize that there's no evidence that opiates improve pain or function with long-term use. Now again, that's been debated. Some people say that lack of evidence doesn't mean that it doesn't exist, and that complete abatement of pain is not realistic. Now I think that's an important point. When I see a patient who comes in my office, I tell them the goal of being here is that you don't suffer, and that pain reduction or pain abatement is not really the goal and is not realistic. The fact that you can be more functional, that you aren't dealing with a mood disorder, that you're part of society is really the goal of any type of pain treatment program. And again, the function is the primary goal. And again, we get so tied into this pain intensity, and patient comes in and what's your pain? Well, it's an 8, it's a 6, I need more opiates. Again, I think it's functionality and mood should be our target for any type of intervention. Patients should be advised about the serious adverse effects of opiates, including fatal respiratory depression or developing an opioid use disorder. Again, that's informed consent. And patients should outline to the patient the common adverse effects, discuss the potential adverse effects that opiates may have on the ability to safely operate a vehicle. Again, all of this needs to be done in a very cogent fashion and probably repeatedly, not just the first visit or the second visit. It should be an ongoing dynamic discussion. Oftentimes we have patients sign a treatment agreement, we go through our spiel about the good and bad things of opiates, and then we don't revisit it 6 months down the road. I think every quarter or 6 months one should pull out that treatment agreement with the patient and say, have we achieved these goals? Are there adverse effects that I'm not aware of? And let's revisit this. So this should be a dynamic, ongoing process. So recommendation 4 makes perfect sense. When starting opioid therapy for chronic non-cancer pain, clinicians should prescribe immediate release opiates instead of extended release long-acting opiates. Now, even though that's a low evidence type 4, I think this is very important. Oftentimes people come in, they've had chronic low back pain, and they may have been on short-acting opiates in the past, and they haven't been on it for a few months, and we immediately go to an extended release long-acting opiates. I really think that's a mistake, and I think this is an important recommendation. Clinicians should not initiate opioid treatment with extended release or long-acting opiates, nor should they prescribe these opiates for intermittent use. So again, I've seen all kinds of patients where they come in and they're on methadone and they're using it on a PRN basis, which makes no sense. When ER or LA opioid preparations are prescribed, suggest using a product with predictable pharmacokinetics and pharmacodynamics to minimize the risk of unintentional overdose. What we're really talking about here is methadone and fentanyl patch, which is unpredictable in many patients due to the long clearance rate in methadone and sort of the unpredictability with the fentanyl patch. Now, unfortunately, when we have patients that have maybe poor insurance, the insurance company might mandate that if you're going on an ER-LA opioid preparation that you start with methadone. Again, I think this is very dangerous, particularly when many of the practitioners that may be starting the methadone because of this mandate are not really familiar with the pharmacodynamics and pharmacokinetics of methadone. So great care should be done, and if you're going to use methadone in your practice for pain, you need to go and get the extra training. You really need to understand this molecule because it's very, very tricky. Recommendation 5, when opiates are started, clinicians should prescribe the lowest effective dose. And again, I just think this makes sense. I mean, the evidence type was 3, but why would you start on a higher dose? Again, I've seen patients come in, they're opioid naive, they come into the physician, say my pain is 9 out of 10, and they start on a high dose. They develop adverse effects, and they discontinue the dose, or they put them at risk for respiratory depression. Clinicians should increase the dosage by the smallest practical amount. Again, when you're in a busy practice and you have many demands, it's very easy to just increase the medication to get the patient out of the clinic. But again, this is unwise treatment. Before increasing total opioid dosage to equal to or greater to 50 milligrams of morphine equivalent daily dose, the clinician should reassess the risk benefits and whether the opiates are leading to the patient's outlined treatment goals. You're in a busy practice, you're in a busy clinic. Again, it's very easy just to increase the dosing and not really think through the process. Now, the CDC picked 50 milligrams where other guidelines have picked 90 or 100 or even 200 as high dosing. And we'll talk about sort of the rationale behind that. The clinician should avoid increasing opioid doses to greater than or equal to 90 MEDDs, or if they do, they should really justify this decision. And again, document, document, document. Now guidelines are not law, but they're interpreted sometimes as standard of practice. So if you're going to be going to a higher dosing than 90, 100, 120, you need to carefully document why and what your goals are and what the goals are achieving, and if you've done due diligence with regards to the patient's risk-benefit profile. Established patients who are on a higher dosing of 90 MEDDs should be educated on the increased risk of higher dosing and encouraged to reduce their dosing. Now, where did this come from? Well, here are 3 large cohort studies, and they're observational studies. So again, these are not gold standard studies, but some of this dosing, ceiling effects have come from these studies. So if you look at these 3 studies briefly, as the dosing went up, the harms ratio significantly increased for the risk of overdose. So this is some of the data that was drawn upon. Again, a lot of it's observational, so it's not gold standard, but this is kind of where those parameters of 50 to 90 milligrams were derived, and we need more research to really look at randomized controlled trials, both on risk and efficacy at different dosings. So if a patient's opioid doses reaches or exceeds 50 milligrams of MEDD, the clinician should increase the frequency of follow-up visits and consider adding naloxone and other overdose precautions to the patient and their household. Now again, this has been a new area that sort of blossomed, is about using, take-home naloxone or the spray or the self-inject, and that if people are at a high risk, meaning that they have obstructive sleep apnea or central sleep apnea, previous history of opioid use disorder, that the clinician should really consider using naloxone or prescribing naloxone as a backup in these cases. There's been some debate about the utility of this, but again, I think it's an important factor to consider. Recommendation 6 is long-term opioid use often begins with treatment of acute pain. Now, this is new to the CDC that was not necessarily reflected in the other previous guidelines. So basically what they said, when opiates are used for acute pain, clinicians should prescribe the lowest effective dose of immediate release, never long-acting or extended-release opiates. Now, this is where it gets a little fuzzy. 3 days or less are often sufficient. Greater than 7 days of opioid use are rarely required. Again, evidence type 4. I think some could suggest that that may be too restrictive depending on the type of surgery you've had. You've had a 2-level spinal fusion, and are you going to be symptom-free in 7 days? So some people have criticized that this is not necessarily, this may be too inflexible as a guideline, but we need to have more data on that. Again, you should prescribe ER/LA opiates for treatment of acute pain. I see it all the time. I saw a patient the other day, opioid naive, post-op, they slapped on a fentanyl patch. It didn't go well. We should not prescribe additional opioids to patients with acute pain with the expectation that their pain may become more subacute or chronic, or for convenience. I don't want to be called after office hours, so I'll give you some extra opiates post-op. Let's look at one study. This is opioid consumption following outpatient upper extremity surgery. These are 250 patients surveyed after outpatient upper extremity surgery. So this is like carpal tunnel, ulnar transposition. 245 of the patients were prescribed opiates. So they were given 30 tablets. They called them in follow-up, and the patients used a mean of 10 pills, whereas 19 pills were subjects reported as unused. So a total of 4,600 leftover tablets were out in the aquifer of the community because of this excessive prescribing of opioids post-op. So again, the authors concluded that excess opioid analgesics are made available after elective surgeries could potentially become a source of diversion. So again, this is some of the data we're drawing on to derive this recommendation. Recommendation 7 is that they should evaluate the benefits and harm for patients within 1 to 4 weeks of starting opioid therapy. Clinicians should evaluate benefits and harm of continued therapy with patients every 3 months or more frequently. If the benefits do not outweigh the harm of continued opioid therapies, they should optimize other therapies. Again, evidence type 4. After commencing long-term opioid therapy, clinicians should evaluate patients to assess any benefits and potential harms of opiates within 1 to 4 weeks. Now, I'm going to challenge this a bit later on in the talk about the reality of this in clinical practice. Again, they should reassess patients at least every 3 months if they're on long-term opioid therapy, etc. Recommendation 8, before starting and periodically during continuation of opioid therapy, clinicians should evaluate risk factors. They should incorporate certain strategies to mitigate risk, including considering offering naloxone when factors that increase risk for opioid overdose, such as history of overdose, history of substance use disorder, concurrent benzodiazepine use. And they should avoid prescribing opioids to patients with moderate to severe sleep disorder breathing. During pregnancy, clinicians and patients together should carefully weigh the risk and benefits. Clinicians should use additional caution and increased monitoring to minimize risk of opiates prescribed for patients with renal or hepatic insufficiency over age 65. These are pretty standard, straightforward risk mitigation strategies. Recommendation 9, they should review the patient's history of controlled substance prescriptions using the state prescription drug monitoring program. Most states have the PDMP data available. There's been some data to suggest that many clinicians don't use it. So I think there's an important factor about, when you're going to be prescribing potentially dangerous medications, that this should be part of your pattern. And they recommended that they should review the PMDD data when starting opioid therapy and routinely when patients are on long-term opioid therapy. Recommendation 10, when prescribing opiates for chronic pain, they should use urine drug testing before starting opioid therapy and consider urine drug testing at least annually. Now, in all of the treatment guidelines, they've all recommended using urine drug testing. However, there has been no consensus about how often. So typically, annually means once a year. Some guidelines have said that if they're at high risk, they should be done quarterly. This is an area where we really need to put some information and collect some information and do some research on, because again, urine drug testing can be very expensive, and it would be nice to be able to look at risk stratification and using this in an appropriate manner. And last note is that you should not dismiss patients. As Doug Gorley says, you fire the molecule, not the patient. Recommendation 11, clinicians should avoid prescribing opioid pain medication and benzos concurrently. Again, this makes total common sense. To any CNS type of medication in combination with opiates can increase the risk of a poor outcome, including respiratory depression and death. And clinicians should really look at the PDMD for concurrent controlled medications, because oftentimes you don't know that they're seeing a psychiatrist and they're started on clonazepam and they forgot to tell you. So again, use this data that's available to you. And if you look at this, most common drugs involved in overdoses in the United States, in 2013 there were 43,000 drug overdoses. 51% were related to pharmaceuticals, 16% involved opiates, but 30% involved benzodiazepines. So people who died of drug overdoses often had a combination of benzos and opiates in their bodies. If you look at ED visits, about 1.4 million involved non-medical use of pharmaceuticals, 50,000 involved anti-anxiety and insomnia medications, and 501,000 and 420,000 involved opioid analgesics. And again, if they're on opiates, they should be encouraged to either look at benzodiazepine types of anti-anxiety or sleeping medications, which are very useful and common. And they should really encourage patients to be reduced or discontinued from benzodiazepine. The last recommendation is that they should arrange for evidence-based treatment, usually medication-assisted therapy with buprenorphine or methadone, in combination with behavioral therapy for patients who have an identified opioid use disorder. And this had one of the highest evidence ratings of 2. Now, let's talk about the reality of practice. And let's look at the barriers of actually implementing these recommendations in a busy practice. So one strong recommendation from the CDC guidelines is non-opioid therapy is preferred for treatment of chronic pain. This can include acupuncture, CBT, physical therapy, chiropractic care, and massage. Well, if you look at the evidence for CBT, it's been found to be very efficacious for a number of chronic pain disorders, including arthritis, sickle cell disease, low back pain, TMJ, lupus, and pain in breast cancer patients. So there's real efficacy in CBT. Another recommendation is that clinicians should arrange evidence-based treatment, usually, medication-assisted therapy with buprenorphine or methadone for patients with opioid use disorders. We have very good medications that are very effective in patients who suffer from opioid use disorders, and this should always be done and combined with behavioral therapies. But here's what the reality is. It is easier to get a handgun than it is to get access to mental health care and to substance use disorder care. And this is the reality. So it's fine and dandy to say that people should have CBT, acupuncture, access to substance use disorders, but there really is a dearth of availability of these services. Many patient psychologists are not trained in pain management. There's an inadequate number of substance abuse treatment facilities and providers. So there's lots of people who have buprenorphine license that take the 8-hour exam, but they really don't have the other components of effective treatment of substance use disorders. There's a lack of access, especially in rural areas, and there's poor or no reimbursement for many of these services. So many of my patients are working class patients, and if you said you need to go to physical therapy 3 times a week, and oh, by the way, that's a $40 copay per visit, $120 per week, they just can't afford it. So it's not just access, but it's poor reimbursement for cognitive medicine. We really need to look at alternative delivery systems. There's many efforts at this. For example, office-based interventions like the screening, brief intervention, referral to treatment, where you embed this in actual medical practices, and they've had phenomenal outcomes in reducing the rate of illicit drug use. A lot what's been discussed is e-health, looking at computer-assisted CBT with some really interesting outcome data from cocaine addicts, looking at the computer-assisted CBT being almost as effective as face-to-face. Telemedicine has been used in the VA for a number of years in treating veterans in rural environments in very complex conditions like PTSD. And there's been this whole onslaught of smartphone apps that have been used in various areas of health. Another thing is education. Now, what does this slide mean? Basically, veterinarians get more training in pain medicine than their medical companions. Veterinarians in Canada receive 88 hours in pain medicine. Physicians receive 8. In the United States, veterinarians receive 15 more hours of pain medicine training than physicians do. And this includes dentists and nurses. So there really is a lack of education in pain medicine and in addiction. I do talks all over the country, and I'll say, how many people, they've gone to medical school, nursing school, how many hours of addiction medicine did you get? Maybe 1 or 2 hours. So we're putting these clinicians on the front line, particularly primary care physicians, with no training in, or limited training in pain and addiction, and asking them to put all of these guidelines into action and to actually monitor this. Another thing is competing demands of the average primary care physicians. You have to do Epic. You have to do electronic medical records and document everything. Oh, and by the way, you have to see more patients and they have to do well in the Prescribing because that's part of reimbursement. It is really difficult. All the recommendations that were made in the CDC guidelines and previous ones make sense. But again, it's a time issue. How do I do this in a busy practice? How can I practically evaluate this patient every 3 weeks and do this risk assessment? A, I don't have the training. B, I don't have the time. So I think there's some real practical issues that need to be addressed. And again, if we look at the complex pain patients, there's a mismatch of patients with chronic pain versus qualified pain specialists. So the primary care docs are the ones, clinicians are the ones that have to care for these patients, and they don't necessarily have the training or resources. And so again, the established guidelines may be helpful, but may not be realistic. And again, lastly, all the approaches to the treatment of chronic pain, the one that has had the strongest evidence of efficacy, cost effectiveness, and lack of iatrogenic complications is interdisciplinary care, where you have everyone working on the same page. This is a quick table looking at the availability or access to interdisciplinary pain management. And as you can see, in most other industrialized countries, there's been an increase of these types of programs, except a decrease in the United States, except for the VA. To put this graphically, the number of interdisciplinary pain programs from 1999 to 2013 have significantly been reduced. So again, even though there's data to support interdisciplinary programs, there isn't access to them. So what's my bottom line? So here's some of the recommendations from the CDC guidelines with some of my additions. Non-opioid therapy is preferred for treatment of chronic pain, but access to these therapies are limited. Opiates should be used only when benefits for pain and function outweigh risks. Again, I would focus on function and mood. The CDC guidelines provide recommendations that are based on best available evidence, which is extremely limited, and interpreted and informed by expert opinion. More research is needed to fully assess key issues, including access to non-opioid therapies, more research on understanding the types of pains, specific diseases, and patients are most likely to be associated with benefit and harm from opioid therapy. And these studies should be real world with diverse patient populations. It shouldn't just be in pain clinics. Assess the effectiveness and harms of opioid pain medications with alternate study designs. Again, need more random controlled trial studies and less observational case studies to really give us the data we need to best manage these patients. Investigate risk identification and mitigation strategies and their effects on patient and public health outcomes. Here's my additions. Need to address the gaps in education on pain and addiction in medical, nursing, and dental schools. Learning the Krebs cycle, again, might make you a better gardener, but it won't make you a better clinician. Fund development of alternative delivery systems, the CBT computer-assisted, the apps that can be available. We need to extend these therapeutic non-opioid therapies to people so that they actually have access to it. And we need changes in reimbursement strategies, which are crucial to allow clinicians the time needed to adequately assess and manage patients with pain. When the average amount of time that a primary care physician has is about 7 minutes to do all of the things that we should do to mitigate risk, it just doesn't seem practical. So we have an opioid epidemic, but as one pain patient said, is we also have a pain epidemic. I think all of those involved in healthcare, including policymakers, insurance companies, clinicians, academic leaders, and researchers, need to work collaboratively to accept the challenges put forth by the IOM if we are going to have any chance to significantly improve pain care and alleviate the suffering of the countless number of patients who suffer from chronic pain. And this is the program that supported us. Collaborative effort of all these organizations, which we appreciate, and thank you very much for your attention. Hello?
Yes, thank you. I am right here. That was really very interesting and certainly makes me understand how complex this whole issue is, particularly, as you say, the lack of addictions education and the lack of pain management education. Does anyone have any questions? I'm looking at the chat box. Robert, are you there? Because I'm not seeing the chat box right now.
I'm here. I don't see any either.
So if you have any questions, feel free to go ahead and put them in the chat box so that we could have Dr. Cheadle answer these for us. We have about 5
answered all of your questions.
What's that?
Okay.
Sorry.
I doubt I answered all your questions.
Apparently you have. I wonder if you could talk a little bit more about the risk assessment tools.
Well, that's an important part, because if you look at the previous guidelines, they all had suggested using the risk assessment tools like the opioid risk tool, the SOAP, the COM. Now, it's interesting, in this rendition, the CDC rendition, they did not. And there's been a lot of recent research that suggests that these tools are not particularly sensitive for this patient population. That their methodology has been challenged. They had like small sample sizes. They were almost always collected in pain clinics where you have a skewed patient population. So the CDC guidelines really de-emphasized that and didn't really mention it. And they relied more on sort of the urine drug testing as a way of looking at risk stratification. So I think there's a lot more work needs to be done on the risk assessment tools, and they have to be done in primary care clinics with larger sample sizes. And remember,
Okay.
a lot of the symptoms that are aberrant behaviors, they're not necessarily surrogates for an opioid use disorder.
Right. Okay, thank you. Thank you so much. We did, it look like, have one question, is there PowerPoint available? And Robert answered that it would be available and archived at INSA's website, which is there, www.insa.org. And there's a link into the webinars. Another question, can we get a PDF of the slides? And the answer to that is also yes, there will be an archive of the slides available. Let's see. That seems to have been a question several times over, so that will be answered. According to the attendees here, we have 307 people attending right now. So if anybody else has any other questions, you can go ahead and type your question in the chat box.
I activated the questions tab, so there's a few that came in there. Do you see them, Dana, or do you want me to read them?
I do not see them, so go ahead and read them, Robert.
Okay. One of them is kind of long, so I will skip that one for now, and we'll answer that one offline and send it to you. Sabrina, I think, asked a long one. Let's see. Do you have any recommendations we can send out to PCPs for dose reduction, excuse me?
Well, I mean, it's very tricky depending on the type of opiate they're on and what other medications they're on. So that has to be sort of an individualized one rather than a blanket one. I mean, typically, if you're reducing opiates, you can be very judicious and kind and do 10%, per week. And some people who are on like methadone, for example, it's a very, very slow taper. So it really, I think, depends on the actual opiate and again, sort of their medical history. So that's something that has to really be individualized.
Okay, next one is med table seems to vary significantly. Is there a uniform agreed table about med?
Oh,
MEDD.
You mean about MEDD. Well, again, I think that we don't have evidence on that, and I think that the slide I showed about the 3 cohort studies that revealed that anything over 100 MEDDs really dramatically increased the harm ratio of having respiratory depression and overdose. I mean, that's where a lot of the guidelines are kind of driven by, but every state is different, and I think that even those cohort studies, people have criticizes that they were observational, retroactive. They really weren't granular in nature. And this is sort of my feeling about this. I think the guidelines are great, but we need more real data. And this is absolutely deficient in this whole discussion about risk assessment. But clearly, the higher the dosing, the higher the risk of bad outcomes. And that doesn't necessarily mean overdoses or developing an opioid use disorder. The higher the dosing, the higher the rate of opioid-induced androgen deficiency, which creates all kinds of havoc. The higher the dosing, there's some speculation that that actually causes REM suppression, and we know that sleep and pain are bidirectional, and that when people are not sleeping, it actually drives up their pain. So I think that we got into the habit in the past is that everyone should be on long-acting plus breakthrough medicine, and by nature, they're going to develop, tolerance pretty rapidly. And so then you end up with very, very high dosing where you're not getting the target of improved function or improved quality of life, and you have all of these other, side effects. And then you have the sort of the psychological dependence that occurs when you try to wean someone off of it, where you say, look, this isn't helping your pain, and we need to look at alternatives. So it's very complicated in managing these patients. And that MEDD, most people sort of, I think that 100 is kind of the benchmark, but the CDC was a little bit more, I think, careful in making that to 50 to 90, but we need more data to support what that really means.
Okay, next one is, what data demonstrate the easier access to handguns than opioids?
That was just a joke.
Oh,
But
okay.
it was a joke. But access is an issue. I mean, maybe I have a big mouth, but I mean, proclaiming that we should do all these things, non-opioids and acupuncture is absolutely wonderful advice. But if no one can get those services, then they're really not very practical in nature.
Okay, are UDSs useful? Recommendation type B.
I'm sorry, repeat that?
Are UDSs useful? Does that?
Oh, are urine drug screenings useful?
Okay.
Is that the question? Sounds like?
I believe so, yeah.
Okay. Well, again, I mean, it's one of the few biomarkers we have. There's a number of different type of metrics. Some people use the oral fluids, some use, blood, but, urine has been sort of the one that's been mostly available, and it is a good standard of practice. I mean, we don't have a lot of biomarkers. Now, urine drug screening, though, you need to have some education on it. I mean, it's not always clear. Even though primary care clinicians prescribe the most amount of opiates, they order urine drug screens the least. And I think part of it is not fully understanding the interpretation. Second is, what do I do with a patient who shows an illicit drug on a Friday afternoon when I'm about ready to leave for vacation? What resources do I have to manage that patient? So I think it is a standard of care. I think it's, again, one of the few biomarkers that are objective. Which is important, and if you're going to prescribe opiates, it should be part of your practice style.
Okay, what recommendations would you have for an addiction psychiatrist planning to work collaboratively with pain management? Example, what you need most from them?
So as an addiction psychiatrist, I rephrase that question, I'm sorry. So what should an addiction psychiatrist know about collaborating with pain medicine physicians or practitioners?
Yeah, what recommendations would you have for an addiction psychiatrist planning to work collaboratively with pain management? What you need most from them?
Well, I think that, a lot of what an addiction specialist will be doing for a pain clinic, for example, and I do this in our clinic, is that basically assessing for patients whether they meet criteria for opioid use disorder. If they do, then being able to provide medication-assisted therapy like buprenorphine. I always recommend that addiction psychiatrists or counselors who want to work in a pain clinic actually get some training in pain management, and there's a number of good websites that I can send whoever on getting some just basic training in pain management, because I think it's really important. At the very least, I would shadow in the pain clinic to really get a good sense of their practice and what their needs are, and what they have in their arsenal to treat pain. But there's a real, I think addiction psychiatrists are extremely important in this dialogue about pain and addiction and pain management, because they're used to dealing with complex patients, and these are complex patients.
Okay, do you know of any clinical programs that have been implemented, the recommendations, a best practice champion, per se? That was kind of a, not fully worded there, but Do you know of any
So,
clinical? Go ahead.
So I think if I'm interpreting this right, and I could not be, is that is there any kind of organization or clinical champion or best practice place that has actually implemented all of these recommendations? And the answer is I don't know of any, because I think they're good recommendations, but in many cases they're not practical. There are very few interdisciplinary pain programs left, and that's a reimbursement issue that needs to be addressed at a policy insurance level.
Okay. There are actually a lot more questions here. So I think what we may do, since we're about 6 minutes past, is take the questions and have you type up answers, and we can have those available on our website along with the slides and the archive. Is that okay, Dr. Cheadle, if we send them to you?
Yeah, and they could also send me direct questions at my email, which is Cheadle, CHEATLE @upenn.edu, and I'm happy to send resources to folks that need it.
Okay. All right, well, I'll log these questions, and we'll get answers online as soon as we can.
Thank you, Robert, for fielding those questions. I'm not sure why they weren't showing up in my chat box, but I just want to thank you again, Dr. Cheadle. I think you gave us so much information. I know myself I'll be going through this again, and it has spurred some other questions that I have, so I think I'll take advantage of your offer to email you. But I want to thank you, and this has been a very, very valuable webinar for us. So thank you once again.
Thank you very much for asking me.
You bet. Okay. All right. With that, everyone, we will sign off. And as Robert has said, this webinar will be available at www.insa.org. And all you have to do is click on the webinar tab. Goodbye.